So my name is Rafat Abonour. I'm a hematologist at IU Health, and I'm the director of the multiple myeloma, Waldenström microglobulinemia, and primary amyloidosis program. Well, we optimizing treatment based on the principle of the treatment of multiple myeloma. So every patient with multiple myeloma should undergo induction treatment, intensification, and maintenance. Now, the induction treatment is evolving. So we have several novel drugs, and we use them in combination. So we need to use the right combination up front because that will provide the best reductions in the volume of the disease. And then following that, we offer stem cell transplantation, which we think is very important. So why do we do induction with combination therapy? Why do stem cell transplant early in the course after induction treatment? Is to really provide the best chance to eradicate all the subclone within the patients. So when you have myeloma patients, they don't have one type of myeloma. Within each patient, there are several clones, and they respond differently. Some clones respond to drug A, but not drug B. And so the goal is to try to eradicate all the clones. Because what happened is that if you just leave behind few of the aggressive clones that they were controlled by the larger clones that they were there, what will happen is that the patient will relapse with very ugly myeloma, very hard to control, especially in the what we call high-risk myeloma. These are the 20% of patients who will relapse within 2 years from diagnosis. Those are very hard to treat. And so for that reason, the best thing is to really get patients into complete remission. Not just complete remission, get him into an MRD negative state. That means if you look at the bone marrow and you try to find a single myeloma cells at 1 in a million and you don't find it, that's called MRD negative. And the data suggests today is that if you get an MRD negative state after the best treatment you provide them, these patients will have a very long remission and very long survival. So our goal here at IU Health is that every patient should achieve a complete remission. Every patient should achieve an MRD negative state. When I started working on multiple myeloma, we used to tell patients, listen, you're probably going to live 2 or 3 years. That was 20 years ago. Now patients are living much longer. And we had patients who we treated 15 years ago still in remission. And they're still living. So why are they still living? Because they are in remission. So it does make sense that if you want your patient to live longer, you need to keep the disease from coming back that quickly. So the longer the remission, the longer they're going to live. So really, that should be the goal of therapy today because we have very good drugs. We have stem cell transplant. You use them together, you get more patient into complete remission, you get more patient into MRD negative state, and what will happen is that will take a much, much longer and hopefully never relapse. So the lasting remission is going to happen when you have MRD negative state. Multiple myeloma is a heterogeneous disease and each patient is unique. So our approach is to really customize the treatment for each patient, with the goal is to achieve MRD negative for each patient that we see. So you have the high risk patient, you have intermediate risk patients, standard risk patients. We will look at every patient to try to find what's the best treatment for them to try to provide them with lasting remission. So we don't have one size fit all, but we want to make sure that every patient has a chance to get a complete remission here. So when a patient diagnosed with multiple myeloma, the referring physician always have in mind, what do we do? They know what's the best induction treatment. The timing of stem cell transplant is still a question. Some people don't think stem cell transplant is important. And what we need to do is to really understand that today, that when you do induction treatment followed by stem cell transplant early in the course of the disease, in the first year of diagnosis, that's when you provide your patient the chances for the best progression-free survival and to improve their overall survival. So our approach has been collaborative approach. So what happened is that the referring physician will say, I got a newly diagnosed multiple myeloma. I'm going to induce them with this combination. We agree that's a very good approach. After 2 cycles, we will see the patient to make sure the patient is responding to the treatment, to make sure the patient is getting ready for the stem cell transplant because they may have dental issue, they may not have their colonoscopy. So we need to get the ball rolling early on. So after 3 or 4 cycles, they are ready to proceed to stem cell transplant. We have 5 physicians specialized in multiple myeloma here at IU Health. And we have nurse practitioners, we have a very robust stem cell processing lab and a stem cell collection lab. We have an excellent unit that staffed with nurses that have been doing this for many years. So when we tell our patients that your chances of surviving transplant is more than 95%, we mean it, because we have all the elements that it takes to make sure that we're providing safe drugs, safe follow-ups, close monitoring. So that's our team. Well, I don't know if I can do anything else. I love the interaction with the patients. I love the patients. I hate myeloma. So my passion is to really take care of these patients. And the most important passion is to really get rid of myeloma while providing them the quality of life they deserve.